Kimberly Gamet is a senior genetic counsellor, team leader at the Northern Hub of the Genetic Health Service in New Zealand. She's been trained in the UK, I think, and she's been working in Australia. She's been working as a genetic counsellor for quite a long time, and as we can see, genetics plays an important part in amyloidosis for a lot of people. So thank you very much.
Thank you, and thank you to Jamie and the Association for asking me to talk today. As you can hear, I am from the UK, but I have lived in New Zealand for 15 years, and my girls have grown up here, so we consider ourselves very well established here now. So my talk is complementary, I think, to Ed's, but it's he's talked about therapies and things like that, and I'm going to talk more about the family implications and what genetic services role can have for working with families. I think as far as amyloidosis goes, genetic services don't seem to have been that involved with some of the families. And I think this is about getting the fact that we are there and we're publicly funded out to the association, and that we're here to kind of help. So Jamie asked me to talk a bit about what genetic services were, what a genetic test was, what role we play, what genetic counsellors do, and really why a genetic test is important, and I think that is evident from Ed's talk. So we are a national service. We have 3 hubs, one here in Auckland Hospital, Wellington and Christchurch, so that provides cover for the country. We're a small service, obviously. There are only about, I think last count was about 16 genetic counsellors in the country, so there's not many of us to cover the population. And we've been a national service since about 2012 now. And we go out and do outreach clinics across New Zealand. When Northern Hub covers Gisborne up to the top of the North Island, so we're quite stretched, basically. Okay, technology. I'm waving it at it, and it's not. Oh, there we go. So, just to say who works in a genetic service, we've got the clinical geneticists that are the doctors that are specialised in genetics, and they normally the ones that make the diagnoses. And in this context, we see everything from preconceptual care to death. So they will often be seeing a lot of paediatric cases, which leaves the genetic counsellors who are very well trained, very with a lot of background and process to get to be a qualified genetic counsellor. We're normally the ones that meet after a diagnosis and meet with the extended family and organise what we call predictive testing, and I'll go into sort of the differences of those. So in the context of amyloidosis, you'd probably be meeting a genetic counsellor, as your diagnosis would happen outside of genetic services. Ed's already talked about this, but I think about it probably a lot more simply than CRISPR and things like that. That when we're talking about what we test, so genes are building blocks of what makes us unique and us. Your genes are amino acids that are always in, I consider them your instruction manual, that are all built with 3-letter words. And those are stored within your chromosomes. You inherit one set of your genes from your mum and one set from your father. So you have 2 copies of each gene, essentially. Oh. Okay. And when we talk about gene mutations, we call them pathogenic variants, and there are subtle differences now according to what a gene mutation or a gene variant is. Okay, not all gene variants will cause a disease. So what we look for in any inherited genetic condition is a gene fault that actually causes disruption to what the gene does. It stops it making the right protein, it stops it functioning. Well, we all carry gene variants because we're all unique, and some of those variants don't matter. They're tolerated by the body. So what we need to have in a family where we've got a inherited genetic condition, we need to know what the specific pathogenic variant is in that family before we can do anything else. Because we do know, and we find more and more now, the more genetic tests we do, the more the improving in sort of genetic technology means we detect far more than we can actually interpret appropriately at this point. So we'll find gene faults that are variants of uncertain significance, and we can't interpret those, and we certainly can't do anything else for the family on the basis of a variant we don't know if it causes the problem or not. There are different, basically disease is a genetic thing, and we acquire changes to our genes as we age, but also we are born with those changes, and what we do in genetics is mainly hereditary, so germline genetics, rather than the acquired somatic genetics, that is actually becoming more and more important in how we diagnose and treat. Thanks. So that's the difference really between what is a diagnostic test, that is doing a test on someone that's affected with the condition, and more now those things are being pushed out into the kind of specialist area, the diagnostic area, and it's part of the diagnostic workup. And when we've got an identified pathogenic variant, that's when we can consider doing testing for families. So the predictive test is dependent on there being a pathogenic variant identified in the family. So when you will see a genetic counsellor, it would be to do a predictive test for an at-risk relative. And that's usually before they've had any clinical symptoms of the condition. So you're in a situation of deciding whether you want to know you're going to, or be at risk, or will develop the condition, or not. And that's, having the diagnostic result matters because we need to know what we're looking for in an affected individual. If we didn't know what we were looking for, we couldn't be certain whether we would find it or not. So it's like having a needle in a haystack, but you know where the needle is. There are obviously over 130 different mutations with amyloidosis, so actually knowing what's specific to that family is important, and as Ed said, you can think about each different family in New Zealand having a different mutation, so we need to know which family it is and what we're actually looking for. I was actually going to take that one out and I forgot to, but that's just really describing a little bit what Ed was talking about, so I'll skip over that. So we also know that the different gene mutations cause different types of amyloidosis. And we also know that our pickup rate for detecting any pathogenic variants of amyloidosis is really good now. The sequence analysis will pick up at least 99%, which is probably, you can interpret as being 100% almost. There are always going to be some things we can't detect with genetic testing. That can be from a technological perspective, or it can be because it's a gene we just don't know about yet. As Ed said, we know that amyloidosis has variable expressivity, so not everyone who has the gene fault will develop all of the manifestations of the condition. We also know that different subtypes have different ways it shows itself, and also family history is still important even when you've got the gene variant, because we still can interpret what may happen to that family on the basis of what's already gone on in it. And also, looking into an ethnic or geographical group seems to make a difference as to how penetrant it might be. So for the Portuguese population with that specific mutation, 80% have the condition by age 50, but only 11% by that age in Sweden. So there are subtle differences across it that we need to be aware of as well. So going back to what we call genotype phenotype, so the specific gene causes the condition and the manifestations of it are the phenotype. And so we see how differently it is and how important it is for us to know what the specific mutation is, so you know what the spectrum of disease is for the condition. And each of those is different, causing the different CNS or cardiac forms of the condition. So genetic counselling is a process, and that's how we always describe it. It's a way of communicating to help individuals cope with the condition. It's not counselling in the traditional way you may expect a counsellor or a psychologist to be. It is about information giving and supporting someone through a decision-making process and supporting them with the outcome of that. So it is greatly about really information strong with a counselling bit on the side, if you like. Okay. So when I was talking about genetic counselling, I said, well, we often will see people who have had a condition diagnosed during pregnancy, through to adult onset conditions. Cancer makes up a huge part of our role now. So many times when we're seeing people, the kind of questions they come to us with will be, well, why has this happened? Why has this happened to me? What's the recurrence risk? Will it happen again? What can I do for my children? Can I prevent it? Can I prevent passing it on to the children? And those are the sorts of questions we are often face in a clinic appointment. And so they're the ones that we aim to help people understand and interpret and support them through those processes, because sometimes we can't actually answer those questions either. As Ed said, it's a dominant condition, so 50-50 risk of inheritance. And as this kind of made-up family history, I wanted to show what we would do with a family if we were referred someone. So if we have the men are square and women are circles, so the man who was diagnosed with amyloidosis at 60 and is found to have a gene mutation within that, with no apparent family history of the condition, we can interpret that in some different ways. We can think, is this a de novo gene fault, and that means it's a new mutation in that individual that's occurred for the first time, or we can't be certain of that, so we would offer to test parents in the first instance if they are available for testing. And then if one of them has the condition, we know it has been inherited and we know which side of the family to consider the testing for. We also need to think, well, could there have been a germline mosaicism risk? And that's when the gene fault occurs within the egg or the sperm. So where it's not caused the condition in that individual, they have passed it on in effect. Now that's a theoretical risk for amyloidosis, because we don't think we've got any figures about if that may be the case or not. Genetic testing in New Zealand, if it is needed, clinically indicated, is obviously publicly funded. When we test for an adult onset condition, we need to test an adult for it. We don't test children for adult onset conditions because we want to ensure their autonomy and their informed consent, so they understand what it really means and what it may mean for their future and what decisions they would want to make on the basis of that information. So ideally we test at 50% risk, because that makes the most sense. You want to test the next in line for inheritance, but obviously we will test at 25% risk. There are some kind of caution to be taken with that, because if the intervening individual did not want to be tested and had actually made that conscious decision not to know their genetic status, then obviously testing their child could reveal their genetic status, so we need to tread carefully in those situations. And how carefully we tread would really depend on the severity of the condition as well. Informed consent's a big deal, so autonomy and understanding what the outcomes may mean and what you can do about them all happens before you do the test. One of the things we do there as well is consider the psychological outcomes of knowing you're going to develop a severe condition and the knowledge that you may pass it on to your children. We also need to think about the people who don't inherit the condition within a family that has got something like amyloidosis, because there's a thing called survivor guilt that no one ever thinks they're going to feel, or will say they're going to feel very relieved if they don't have it, but in the context of a family with sick siblings or parents, it can be quite a difficult adjustment not to have the condition, because actually it's like the absence of worry for yourself, but actually also seeing family members and the why me, why not me. So those are the kind of things we spend some time talking to individuals within families about. Although we often see an individual that very much is a family area of medicine, we always think about families, we always think about the impact on the wider family when we do these tests and what it may mean, and encourage that communication. Would be awful to do a genetic test or a diagnostic test on an individual who refused to share that information with family members. And from our perspective, wouldn't be one we really want to engage in. Except that's now obviously challenged when the treatment implications are so much more important. So one of the things Jamie asked me to say is why have a predictive test? I said they're publicly funded. Diagnostic tests can take, depending on the lab involved, can take about 10 to 12 weeks to get a result back. Predictive tests are a little bit shorter, but again, lab dependent. If it's overseas, it takes longer. All of those issues about sending things around, particularly now during COVID, some labs won't even accept overseas samples. So turnaround times we can't get any shorter than that at the moment, but I'm sure they will continue to reduce as technology improves. But the importance of a predictive test in this context really is thinking about the therapeutic value. We know, as Ed's been talking about, there are more therapies that are becoming more effective, and also the potential of future treatment and the expansion of the treatments that are already being researched, then being expanded into the other types of amyloidosis. Also, considering in the family setting, knowing that you will develop the condition, can't stop that happening, but we certainly can't determine how it may happen, when it may happen. Age of onset can be incredibly variable in all families. But what we can do is make sure people are being screened effectively, and that's where family history comes back into it as well, because you want to start screening younger than the youngest onset in the family member. And so we can make that plan going forward with those people. So the earlier the diagnosis and the more effective the treatment effectively. We also can think about other options for families too. So reproductive options are an increasing request that people want to have more information about. Now, whilst we can't always test for a condition when we've got a gene fault in a family, doing a prenatal test is a little bit controversial in the context of an adult onset disorder, where there is treatment and where that treatment is becoming more effective and certainly less invasive. So with adult, really there are two reasons anyone would do a prenatal test: is to end a pregnancy if it's affected, or to be able to plan and adjust to the information. In the context of an adult onset disorder, if you are intending to continue with the pregnancy, you're actually just done a predictive test on an unborn. And we don't test children, so it wouldn't really be a wise idea to do that, because there are many reasons why you wouldn't want to do that around worry, fear for the child, and maybe missed opportunities for the child as they grow up, knowing they're going to develop a condition. So there are many ethical considerations we would discuss with a couple if that were the case. It's not necessarily something you could refuse to do, but I think the support for it from a medical perspective would not be very strong. Also, pre-implantation genetic diagnosis, or genetic testing as it's called now, is offered in New Zealand. There is public funding for serious genetic conditions. There are 40 cycles a year. There you go, done it. Yes, so the public funded in New Zealand for 40 cycles a year, but this is for all serious genetic conditions, so anyone wanting to do that, and within Auckland there are 20 a year, so there are waiting lists for this because it covers everything. This is a method of basically taking an embryo prior to implantation in the uterus and testing it to see whether it has or has not got the condition. It's IVF, so you have to go through all of the IVF, assisted reproductive technology meds, but also there are other rules around IVF, around BMI, age, how likely you are to produce enough eggs to get some kind of favourable outcome. In doing that, the reason for doing that is because you don't know how many eggs you're going to produce, you don't know how many embryos they're going to result, you don't know how many embryos would continue to develop past the biopsy stage of day 5. So in some respects it actually reduces the chances of having a pregnancy, but it does mean you are avoiding passing on if that was your choice to do so. There are different types of pre-implantation genetic testing. This is for Mendelian disorders, and there are others that are around now, not all publicly funded. The rules around PGT may well change as well if it's the more people wanting it and the cost of $1,000, they tend to really review the criteria for eligibility. So that's just sort of a picture of your biopsy on day 5 and look at one cell from that embryo. Just going back to prenatal diagnosis, they always would, the lab always recommend prenatal diagnosis to confirm any good result during any pregnancy. And that's just totally up to the couple and how the certainty they want. PGT normally has about 95 to 98% certainty that it's okay. And these diagnostic tests are the only ways of checking that. Insurance implications really have been changing over the last few years, and the fact that Australia put a moratorium on insurers up to certain levels of life or health insurance for asking for genetic information or family history information. New Zealand have not done that yet, and they will ask for genetic test results or if there have been any genetic tests in a family. It has proved to be some of a deterrent to genetic testing, but having said that, if you balance that against the successes around treatment or surveillance for conditions, I think still genetic testing wins on that one. They have reviewed this recently in the insurance companies here, but it's not been a transparent process, so I'm not quite sure what their decision making is or if we'll be able to get any moratorium. So, you go taking that. Oh, thanks. So just really to summarise, we can do predictive testing if there's a diagnostic mutation in the family. We can't tell you how it may happen, what manifestations may occur, what age that may occur at. We can certainly make a plan for what treatment or screening is useful for the family, depending on the type of amyloidosis. And the point of genetic counselling really is to help an individual consider if they are making the right decision for themselves, to determine what plan would work for them, and also to consider what other options they may want to make on the basis of their result. And that's kind of what genetic counselling, genetic testing does here. So it's talks have been quite generic after Ed, so yeah, I'm seeing there were some questions for Ed already, so